It's up to you.
Thank you, Jean-Luc. Florence, that was the best talk I've heard from a radio oncologist ever about pancreas cancer. You make my talk a little bit easier because I'm going to cover some of the same material that you had, perhaps from a slightly different angle, but it's still the same set of data. Where do I point this to? There we go. It's a conflict of interest. I think the first thing to say is we've heard from Andrew Rim today, who's one of the key individuals that provided very, very powerful evidence that with pancreas cancer we are dealing with a systemic disease from the word go. And we need to bear this in mind. People ask me why I thought chemoradiation didn't do well in SPAC1. And I said I didn't really know. But it's becoming clearer, and I think we may see this as we go through the talk here, that you're not giving systemic therapy for the period that you're given the radiation treatment. And we know from classical oncological lessons that you need 6 cycles of chemotherapy to kill the cancer cells, otherwise they just regrow. And maybe it's as simple an answer as that. Or alternatively, it may be, as we've seen from LAP07, that chemoradiation actually promotes metastases. And that's very well borne out by animal experiments that show giving radiation to rats with pancreas cancer get more metastases. So these are the different options to think about. Now, the SPAC1 design is not as simple as some people think. It contained a 2 by 2 factorial design. In other words, we randomized each patient twice. So we randomized them to observation versus chemotherapy, i.e. chemotherapy, yes, no. And then we randomized them to chemoradiotherapy, yes, no, which sort of created 4 groups. But it's not a 4-arm study. It's a 2 by 2 factorial design. So why did we do that? Well, the largest trial up to then had been GITSIG with 49 patients, and that had taken 8 years to complete. Nobody thought we would complete the trial. Nobody thought we would start the trial, let alone complete the trial. So that's why we had it that way. And that was a pure randomization. But we're also pragmatic, and we wondered whether people would just want to choose chemotherapy versus no chemotherapy, leave it at that, or just choose chemoradiation versus no chemoradiation, just that, leave it at that. The radiation that we used was exactly the same as used in GITSIG. So if we found a different result, it wouldn't be because we'd used a different regimen. We wouldn't have that argument. Of course, the trial was analysed by intention to treat. And as you know, in most of these studies, around about 10 to 15% of patients do not receive the intended treatment at all. So bear that in mind. Okay. So the first thing that happened was a bit of a surprise in that the Data Monitoring Committee told us that we had to report the findings in the overall study. So we call this SPAC1+. That's in all 541 patients, which is the 2 by 2 factorial plus the patients in the pragmatic randomization, that we found that the chemoradiotherapy arm was not good. Whereas the chemotherapy arm, sorry, this is chemoradiation here, that was tending towards a harmful effect. But that wasn't the case in the chemotherapy arm at the time. So it's very, very important that we had to report it because of ethical reasons. The Data Monitoring Committee and the Lancet felt that that we shouldn't be continuing with the use of chemoradiotherapy, although by this stage, of course, we had reached target accrual. When it came to the final results, in other words, when we reached the number of events that we'd calculated, New England was interested, but they were really interested in the 2 by 2 factorial, and that can be appreciated because actually that told you what the answer was. And the answer was that chemotherapy was good versus no chemotherapy, and that chemoradiation was not good. And that's straightforward. And the Americans have continued to fail to understand what a 2x2 factorial design is. Of course, until the latest RTOG trial, the one they're doing now, is actually a 2x2 factorial. So it's taken them 10 years to understand what a 2x2 factorial study is and that it's good to use. This is the trial that Florence has already referred to. Now, Bill Regine is a good guy, and he rang me up about this trial and its design. And I said to him, Bill, it's rubbish because it won't tell you anything. He says, I know, John, I know, but we have to do something. And the problem is, of course, is that you're comparing two types of chemoradiation. More modern, more fancy, but still two types of chemoradiation. And you're still lacking proof of concept. So the plan was anyway that they randomized 538 patients. They didn't like 100 for some reason, so they got rid of those. And they didn't like the results of what they got with those 451. So then they said, well, let's just have a look at the 308 with head tumors. Now, these are, you know, post hoc decisions, really not acceptable, and really shouldn't be going into good journals, but nevertheless, here it is. And of course, there was no difference between the two arms, as predicted. And similarly with the head of pancreas, there's no difference. But what I want you to look at is median survival. It's about 16 months. And the median survival we got in SPAC was over 20 months. This is after they've eliminated more than 100 patients. They've all had treatment. In SPAC 1, it's intention to treat, and 15% of patients didn't have treatment. Here, they are using more advanced therapies. So they told us that in Europe, you don't know how to give chemoradiation. We can only give chemoradiation in the United States. I know we shouldn't compare one trial with another, but the differences are quite marked. A median of 16 months versus a median of 20 months is a big difference. And all credit to the Journal of the National Cancer Institute. They wrote a swingeing editorial, you know, of that publication to say, look, you guys who give radiotherapy, you talk an awful lot, you're very critical of SPAC, but actually it's SPAC that is showing us how to do proper trials. So we used 5-FU in the original SPAC 1 trial. Gemcitabine came along. We felt that the two had to be tested. Initially, it was a 3-arm trial because we hadn't quite got the final results of SPAC 1. And so the version 2 study collapsed the design of the trial into just 2 arms. So sometimes you'll hear about SPAC 3 controls, but they don't feature in this analysis. And very interestingly, and this was actually a very, very, very important finding, we had that the median survival was no difference between the two studies. There isn't even a hint of a difference that gemcitabine is better than 5-FU. Of course, gem has got a slightly better toxicity profile than 5-FU. That's not the issue. But the issue is that 5-FU is a very powerful cytotoxic against pancreas cancer. So to people like us, we were not surprised when FOLFIRINOX was shown to be so powerful when this was produced by colleagues in France. And so this really changed the state of play, that we can now look towards gemcitabine-based regimens, or we could look towards 5-FU-based regimens, or even think about combining the two in this setting. And with 1,100 patients here randomized, we've now got a median survival of 24 months. And a survival rate that's going out to 8 years, which is on good numbers. The Japanese in a Japan population have similarly shown S1, which is a triple agent which basically boosts the activity of 5-FU whilst minimizing toxicity, had an even better result here. We've tried to encourage the company Taiho to try and do something similar in Europe, but S1 has gone off patent, and they're focusing on the Asian trade for commercial reasons. Still not published. Okay, so this is the network meta-analysis that Florence mentioned. And we were asked to do an editorial on it. Trevor Cox is one of our statisticians. And basically, this summarizes what's gone on here. Florence, we are also doing an updated network meta-analysis using IPD, individual patient data, on more studies at the moment. One of the things that a lot of our medical oncologists asked and continuously asked was, when do we start the chemotherapy? How much chemotherapy do we start? So is it better to start early and give as much as you can, or is it better to wait until the patient's fitter? Now remember that because it's pancreas surgery, you know, a lot of patients are taking 8, 10, 12 weeks to start their chemotherapy because they're still recovering. What do we do? So interestingly enough, we could actually ask that question by going back and interrogating the data. And we did this in an anonymized manner. So the question was, before 8 weeks or after 8 weeks, between 8 and 12 weeks. And what we found was very, very interesting, that if you gave the chemo early, i.e. 8 weeks or less, or late, 8 weeks or later, it didn't make a blind bit of difference, which is interesting. What mattered was you have to give 6 cycles. You have to give 6 cycles. And that is, again, coming back to very basic oncological treatment that you get in your introductory course when you're learning about medical oncology. You have to give 6 cycles. And these are you can count them 1, 2, 3, 4, 5. It's that magic 6 cycle that seems to make the difference. Right, so I just want to come back to this here. So what is it? Well, I think having observed a lot of these patients over the years, if you start too soon, the patient has still got some fatigue. You start your chemo, they get more fatigued, and then they say, I can't do this anymore. Whereas if they're fully recovered at, say, 12 weeks, they're feeling fit, they're ready to go, they're ready to have those 12 weeks of chemo, you know, they're in a better place. You know, as we've heard already, they're in a better place to have that 6 months worth of chemotherapy. You know, people can show you different, you know, some patients do better than others. Well, of course they do. Better by stage, better by grade. Lymph nodes, simple thing like lymph nodes, you know. If you're R0, this is R0 versus N1, sorry, N0 versus N1. I mean, there is a huge difference here. The surgeon has a role. We remove what we can remove. But as Professor Buchler has said, there is a spectrum of disease within the patients with pancreatic cancer. Some will do very well. So we've heard the argument about R0 and R1. Now, it's a very strange thing when you go to ASCO or other places in America and you hear the American surgeons lecturing us about R0 and R1 when we were already well ahead of the game. So when we saw that we had 19% R1 resection rate in the SPAC1 trial, we wondered why. But we also realized that we needed to standardize the definition of R0 versus R1. So when we started SPAC3 in you know, long time ago now, 2002, we'd already defined what R1 was, which is that 1 millimeter, less than 1 millimeter from any resection margin. So we're not surprised about the result that we've got. Now, the higher the R1 rate, actually what that tells you is you've got a better pathologist. So although in SPAC3 the R1 resection rate is 35%, in Liverpool it's 70%, and in Heidelberg it's 70%. Why? Because we've got extremely good pathologists. But we still have to think about this, we have to do this, we've already seen this. And this is our definition. This is an R1, okay? In America, they would call that only an R1 margin, but in Europe we would call that an R1 margin. So there are differences here. And this is a study, it's identical to the one that came from Heidelberg with Irene Esposito, but basically there is a difference between an R0, which is less than 1 millimeter, versus direct and indirect. So it's very, very, the reason I'm raising this is because we need hard endpoints. And if you read some of the American papers, and their primary outcome measure is the R factor, it's because they're using a soft R factor. Whereas in Europe, we use a different R factor. So you have to be very, very careful about comparison. And again, this is why it's so important to look at randomized trials. Yes, finally, we've shown a difference between R0 and R1, partly because the numbers are bigger, partly because the pathological reporting between R0 and R0 is that much better. But even so, you can see that even with an R1 resection, we have a median survival here of 20 months, which is still better than the radiotherapy RTOG trial of bilirubin with 16 months. So we're doing better with an R1 and chemotherapy than the Americans are doing with all their chemoradiation and lots of R0s. Okay. So SPAC4 is a trial which compared gem with gemcitabine and capecitabine. Why capecitabine? Well, it's a combination which has double the objective response rate in advanced cancer, a tendency to better survival, and also acceptable toxicity compared to other potential couplets. So it recruited ahead of target, and if you want to hear about it, you need to go to ASCO, because I'm not telling you now. But you won't waste your journey. Borderline resectability. So we've heard a lot about this. Well, we all have this, where you've got a non-resectable tumour. I mean, Professor Buchler would resect it, I would resect it, but by definition, it's not a resectable tumour, and it does get downstaged, and it does get removed. What is a resectable, non-resectable tumour? Well, it's different from Professor Buchler than it is for any other surgeon on planet Earth. There are people that have decided, this is the MD Anderson classification, yes, that's resectable. There's a fat plane here. Clearly, this is not resectable. The argument goes when you have things in between. So that's one classification. The same kind of things are used. This is another classification here. The Surgical Association of American Surgeons here, that's their classification. Similar parameters, similar kind of definitions. But if you apply the same definition, sorry, this is one paper. If you apply the same definition to the same group of patients, you get a different answer. So these are two classifications, same patients, different answer. So you can't even agree there. And so this is an attempt to rationalize this. Okay, so this is what's in the NCI guidelines from North America now. But what is allowing safe resection? What is encasement? And what is abutment? What is the difference between all of these? Well, it depends what day of the week it is. You know, I like one beer one day. I may like another beer the other day. So this was talks we had in SPAC going back many, many years in terms of how you might classify it. And here you've got 1, 2, 3, 4, 5 classifications. In the end, we decided going forward in a randomized trial that we would settle for something simple. So you've all seen this. Now you've got to remember that these data that are generated here are largely from non-randomized studies. So you can't draw any conclusions from this. What you can draw are notions to drive a hypothesis. So what you see here about neoadjuvant in the resectable setting is that these are similar. So it's not a question here. If neoadjuvant chemotherapy gives you the same result in resectable patient as adjuvant chemotherapy gives you, it's not a question, because it's the same. So why do you want to find the same answer? But here, of course, there is a question here, because in the neoadjuvant setting here, that's a question. That is not a question. Sorry, it's just illustrating how you use data. Now, the problem with a lot of neoadjuvant studies is that you start off with 100, but you end up with 60%, and they report on the 60%, and they say, oh, what good results we're getting. Well, no, they're not really. And so I think it's Florence, one or two other people have mentioned, is neoadjuvant treatment is clearly not giving you better results. That's for sure. It's giving you the same results. But you're refusing. Are you refusing treatment to these 40 patients? Well, yes, you are. You say, but we're selecting the ones who would have got a recurrence anyway, metastasis anyway. How do you know? Unless you're randomized, how do you know? How do you know you haven't denied these patients proper treatment? You don't know. So before people go rushing into using neoadjuvant treatment, just think what matters is that patient in front of you sitting there. What's the best thing to do for them? Look, you might die. So we're going to wait to see if you're going to die. And if you're not going to die, after a few months, we'll operate on you. It's not very human, really. And in terms of what is achieved at the end of the day, none of it's terribly dramatic. And, you know, we know RECIST criteria aren't so good for predicting resectability, but all that neoadjuvant treatment seem to have done is to have produced a lot of progressive disease. That was the title of their paper. It got published in Cancer, which is sort of journal. But I think this is true. I think we can't use RECIST criteria. But what was the objective response? They say response. There was no response. So please don't get carried away by the enthusiasm of authors. So this is a bit of a year old since I looked at this, but there are 38 trials going on of neoadjuvant trials. There's not a single trial, randomized phase 3 trial going on in the United States. The vast majority, I'll come on to this one. Where you have phase 3 trials, this is a randomized phase 2, SPAC5, and there's a randomized trial going in Korea. The randomized trials here are all occurring in Europe. All these are occurring in the United States. Yeah, of course you have to do phase 2 studies, but then you've got to move on. And I think the failing in, our failing as a community is that we're not doing more phase 3 studies. So what are SPAC5? Well, we want to see if we can increase the resectability in borderline resectable patients. And what we've simply done is, you know, resectable becomes irresectable when we lose the tissue plane between the vein or the artery or both. We have central review, so there's no, everyone's treated the same. What chemotherapy to use? We look to our brothers in France, the Tricolor, and we say, yes, FOLFIRINOX, we must use this. Fantastic result. Problem is, it's toxic, and you really do have to normalize LFTs before you use it. So there could be an issue there in terms of applying this on a generality. So this is why we also included GemCap. It's a little bit of a niche combination, but it does have a good objective response rate. Not as good as here, but that's the reason there, and an acceptable toxicity. The chemoradiation that's going into SPAC5, we chose Scallop 2. This is a randomized trial, has less toxicity, and it's the obvious thing to do. It's a tested regimen. So this is a 4-arm study where we're comparing straight to surgery, GemCap, FOLFIRINOX, chemoradiotherapy. We will see which of these arms is the best. Now, if they're all roughly the same, and if we've got roughly the same toxicity, then we'll have a 4-arm trial. Hopefully, we can cut this down to a 3 or a 2-arm trial, but again, still having the control group of straight to surgery. So there are other things that we might use in the adjuvant setting or the neoadjuvant setting. One of the interesting things that's around at the moment is irreversible electroporation. So one of the studies that we're planning is upfront FOLFIRINOX, and then plus or minus irreversible electroporation if that if it's still not resectable. If it's resectable, of course, we'll go to surgery. It's only by doing randomized studies that you can get information that's not biased or minimally biased. You can get tissue. We can look at why R1 patients do worse. It's not just the fact that they've gone to the margin. There's probably something intrinsic within that R1 tumour that has made it worse. Unless you know what they are, unless you collect the tissue prospectively, then you won't be able to tell what that difference is. Now, there is a trend that we should all spend £10,000 on a patient to get whole genome sequencing on their pancreas tissue, and that will somehow tell us how to treat them. Maybe, but it's unlikely. So I think there's a lot of, so I'm not going to talk about that, but what I'm going to talk about is where we've got to now. Because where we've got to now is we have active drugs in pancreas cancer. We can use them cleverly, can't we? We can look at biomarkers. And this is straightforward. Everyone's familiar with this. This is the equilibrative nucleotide transporter pathway. Jean-Luc, among others, has been those sort of pioneering, looking at these therapeutic response markers. This is what we tested. So we've collected these tissues, randomized setting. We've taken samples at random. We've put them into TMAs at random. And then we've put onto these validated antibody onto these to see what goes on. All blinded. It's run as an experiment. As all of you, I'm sure, know, the most important thing about science is the control arm. It's not the intervention arm. It's not the experimental arm. The most important thing in an experiment in the lab or in the clinic is the control. So bias was removed. Nobody knew what they were scoring. Very, very interestingly, what we had, that survival for gemcitabine was much higher in the group that had high expression. It seemed to be the opposite, although not quite, for 5FU. Is this what we should be doing? If this were true, we could double survival. If this were true. There are other markers out there, some of which are in the public domain, some of which are not in the public domain. And so this is, I know this looks crazy, but this is going to be our next adjuvant trial. This is resection. And these patients will be fed in different ways. Some are resectable, and they will have window studies going on. They will have neoadjuvant treatment going on, and they will be randomized based on these blocked out boxes here, which I've not put in. We are going to look at things like BRCA, BRCAness, and mismatch repair genes, because that can determine a particular type of treatment. But you don't need to sequence the whole genome to be able to do that. You can just do it. We are going to look at organoids. This is where you grow human tissue quickly, and you're then able to interrogate those organoids for their signaling pathways and their genetic makeup, and potentially identify master regulators. And then coming down into the adjuvant context, we then need to start defining which markers really are predictive in a prospective setting in a real world. One other reason you should go to Chicago is PET-PANC. This was a study led by Liverpool. It's a 600-patient cohort study. Everybody got PET, and the whole thing has got analysed, and the results will I think, be very, very important to the way we diagnose, stage, manage patients in the future. I can't tell you what the results are, but it's good. Gemabraxane, I don't know what we do with that. There is a difference. A few weeks, lots of toxicity, maybe good, maybe bad, I don't know. But that's certainly something that we need to consider. But it needs to be done in an intelligent setting. So really, I don't have any great conclusions. They're all fairly standard conclusions. Be careful about reading the data. But the future has to be about more randomized trials. And if you're going to do randomized phase 2 studies, then I think they should be really integrated into a phase 3 endpoint rather than to generate yet another phase 2 study. Okay, so thank you to lots of people, and thank you to, well, thank you.